My name is Dr. Tiffany Kelley. I am a nurse, and I serve as the DeLuca Foundation Visiting Professor for Innovation and New Knowledge at the University of Connecticut School of Nursing. I am here today to speak with you on the topic of addressing the patchwork model of healthcare through innovation. Patchwork. When I hear the word patchwork, the image that comes to mind is that of a quilt. Quilts are made up of dozens of different patches sewn together to form a single unique work of art that serves a functional role for the intended consumers of the product. A patchwork framework is appropriate for items such as quilts and blankets. However, such a framework is not ideal for an industry such as healthcare. Healthcare is an industry that is charged with caring for the health of humans. As humans, each and every one of us will seek healthcare services at different points in our lives. When we seek out those services, we are extremely vulnerable and place great trust in the knowledge, skills, and abilities of our nurses, physicians, and all other healthcare workers. Evidence shows that such trust is consistently earned by the public. Nurses have been voted the most trusted profession for the last 18 years in a row by the Gallup poll. However, the trust does not stop with the nurse or individual healthcare professional. The nurse, physician, and/or healthcare professional cannot provide the highest quality of care alone. Thus, we are also placing this trust in the organizations in which we are receiving our care. These organizations may include outpatient clinics, specialty care centers, local community centers, hospitals, nursing homes, long-term care facilities, and more. These organizations are complex systems with many interdependencies. However, the common underlying goal is to deliver the safest, most effective, efficient, equitable, timely, and patient-centered care as possible. The Institute of Medicine identified these 6 measurable constructs as the core elements of quality in the seminal report Crossing the Quality Chasm, published in 2001, nearly 20 years ago. 20 years ago, I began my career as a nurse after graduating from Georgetown University. I could not wait to become an RN, a registered nurse, and begin my work as a bedside nurse at Children's National Medical Center in Washington, D.C. 3.5 short years later, I had found myself having worked at 3 pediatric academic medical centers across the United States. I came to understand that there were systemic gaps that were preventing me from being able to deliver that quality care I had strived for each day as an individual nurse. Such gaps are opportunities to positively change, or said another way, innovate the way in which care is delivered to patients each day. Addressing these gaps would improve the day-to-day experiences of not only our nurses and healthcare professionals, but also the experiences of the patients in need of care. However, at that time in my career, I did not have the right knowledge, skills, or abilities to know how to address the gaps I faced each day at a systemic level. Instead, I would continue to patch things together the best that I could on my own each day through the use of workarounds. So what is a workaround? Workarounds are temporary solutions to operational failures within an organization or system. Workarounds are also clues of system-level opportunities to innovate or bring positive change to healthcare. Nurses spend nearly 10% of their shift on workarounds. This amounts to approximately 65 minutes per 12-hour shift and 25% of the hospital's budget. For those unfamiliar with what a workaround in healthcare looks like, let me share 2 common examples, familiar to most, if not all, nurses. The first involves the linen cart. As part of my morning routine in caring for my patients, I strive to change the bed linens and patient gowns to help my patients feel refreshed and clean while in the hospital and starting their day. However, every time I would visit the linen cart on my patient care unit, there was never enough linen on the cart. To patch or work around this gap, I would go to another patient care unit and take linen from their cart, thereby leaving them short as well. I did this nearly every day, and I never mentioned it to my nurse manager. I thought this was just the way that it was. I never considered that there could be another way. I also never realized how pervasive this workaround was within our profession until I began to use it in my public speaking talks, and seeing everyone in the audience was giving me visible affirmations that they too had run to another unit to grab linen for their patients. Consider the valuable time lost here, day after day, for a simple, solvable system-level gap. Nurses should not need to spend their time chasing after linen, especially when we know that over 1 hour per shift is wasted per nurse each day on workarounds because of these operational failures. The second workaround example involves the lifeline of nurses' information needs, a scrap piece of paper, often referred to as a nurse's brain or report sheet. Nurses rely on a scrap piece of paper at the start of their shift to collect and temporarily store all of the information nurses deem necessary to know their patients for the delivery of individualized quality care. A scrap piece of paper, not part of the patient's medical record, and shredded at the end of each shift, is the nurse's current lifeline to knowing their patient. Sometimes throughout the day, nurses will also rely on other temporary sources, such as a paper towel, tape on one's pants, alcohol prep pads, Post-it notes, a glove, or even one's own hands to jot down vital patient information that needs to later be recorded in the electronic medical record. In what other industry where vital information is gathered does one rely on a workaround, such as scrap papers and paper towels, because a system-level solution does not exist? These are just two examples of many workarounds that permeate our healthcare system. However, these two examples represent opportunities to address the systemic gaps that are currently being patched together through workarounds by nurses and healthcare professionals each day. Workarounds have traditionally been seen as hidden practices and not often discussed or prioritized as opportunities for positive change in healthcare at an organizational or system level. We cannot begin to address these workarounds that contribute to patching care together for patients and continue to frustrate our nurses and healthcare professionals if we do not see them as clues for how to improve care quality. We must also begin to provide the appropriate knowledge, skills, and abilities to our nurses and healthcare professionals to develop a culture and infrastructure that allows room to address these opportunities that are keeping us in a more reactive state than proactive state. A reactive state is when an individual or organization responds or reacts to a presented challenge. A proactive state is when an individual or organization anticipates potential challenges that could arise in the near or distant future and develops products, processes, or services that will be available to address such challenges when the anticipated unmet need arises. Now, I am speaking to you today in October 2020, 7 months after the World Health Organization declared a global pandemic on March 11th due to the coronavirus. 2 days later, on March 13th, the United States declared a national emergency. From that point onward, all attention turned toward the healthcare industry. More specifically, concern for those who contracted the coronavirus, concern for the nurses, doctors, healthcare professionals, and essential workers who needed to continue to show up and perform day after day without knowing if they might contract the coronavirus by helping in or caring for others in need, and concern for how best to protect the public from contracting the coronavirus to the extent possible. We saw that we were not prepared for what came our way this year. As a result, we had to react as quickly as possible to patch together the major gaps that emerged around a shortage of masks and other personal protective equipment, ventilators, bed spaces, diagnostic tests, and even a need to mobilize nurses, doctors, and healthcare professionals from across the nation to emerging hotspots. From these needs, we saw many innovative behaviors emerge that resulted in workarounds at scale. We saw nurses placing their N95 masks in Tupperware containers to conserve the mask for many days, if not weeks, beyond the intended single use. We saw the general public initially making face coverings out of their scarves, t-shirts, and bandanas at home at the advisory of the United States Surgeon General on April 3rd. We as a country reacted and adapted to the needs at the current moment in time to allow for the system to catch up. In some cases, we still have not caught up and continue to be in a reactive state. Yet, there were instances where we were prepared and able to be proactive in the care of human health. On March 17th, 4 days after the United States declared a national emergency, and 6 days after the World Health Organization declared a global pandemic, the Center for Medicare and Medicaid Services permitted the broader use of and payment for telehealth services. While many of us may have experienced our first telehealth visit within the last 7 months, the technology is not new. The concept and innovation dates back to the 1960s. As a country, we could not have adapted and brought this positive change to healthcare if innovators had not anticipated the need and possibility of telehealth care as a new service model years before it was truly needed at scale. More broadly, we saw digital video conferencing platforms such as Zoom, FaceTime, and WebEx being used at scale to permit the social distancing required of our population in an effort to reduce the risk and rate of coronavirus transmission, while continuing to keep work, school, and other activities ongoing as much as possible. Think for a moment about what if the innovators who proactively created these innovations to address anticipated unmet needs of the public had not done so. What might the last 7 months have looked like if these innovations were not available? I do not really want to know the answer to that question, and I suspect you do not either. What I do know is that the innovations that were available to leverage at scale helped us and the healthcare industry when we really needed it. Our healthcare history demonstrates that innovators have consistently emerged to address gaps in quality care through the development of new innovations. Consider being examined by a healthcare professional without the use of a stethoscope. Being in an emergency room during a code situation without the accessibility of a crash cart. Caring for a child postoperatively without a way to effectively measure the child's pain levels. Or needing to administer blood to patients without access to resources such as the American Red Cross. There was a time when these life-saving innovations did not exist. Nurses, doctors, and other healthcare professionals saw the unmet needs that were being patched together and affecting the ability to provide consistent quality patient care across the population. So what if we could change our expectations to become more proactive in healthcare by preparing our nurses, doctors, and healthcare professionals with the knowledge, skills, and abilities to not only identify the gaps being patched together for care today, but to actually be empowered to lead and solve these challenging opportunities. I can tell you this is not only possible, but I see it happening in students across all degree programs every week in my role here at the UConn School of Nursing. More broadly, we are all able to identify gaps or unmet needs. This often manifests itself in complaining. However, we are not all confident that our ideas are good enough. Somehow, we've presented a mainstream idea that innovators are a select few, maybe even genetically predetermined at birth. However, research shows us that up to 70% of one's creative ability can be learned. This means that we can educate the future and current generation of nurses, doctors, and all other healthcare professionals how to not only proactively identify gaps in quality of care that may be patched together today through workarounds, but also how to address them at scale through an innovative approach, thereby impacting all who are affected, not just that one patient on that one day. Secondarily is the need to develop a culture and infrastructure within these healthcare organizations that provides pathways for someone to come forward with an idea and execute in a systematic and supportive way. What if we invested in our current and future generation of healthcare professionals in a way that gave them the tools to not only identify the problems affecting the safety, efficiency, effectiveness, equitable, timely, and patient-centeredness of care delivery, but more importantly, know how to solve them for the betterment of society? Imagine what healthcare would look like 3, 5, or even 10 years from now if every nurse, physician, and other healthcare professional took just one identifiable gap or workaround and made it their mission to solve. I believe this is not only possible, but to not provide the tools needed to do so is not only at the detriment to the individual's capabilities, but also to the detriment of future health. Therefore, I ask each of you listening to reflect on how you too can contribute to the greater mission of driving higher quality care by striving to remove the patchwork in healthcare, by embracing the power innovation holds, and helping advance human health. Thank you.